Thank you very much, all of you, for this nice presentation. My question is to you, Corey, regarding the fibrosis or fibrotic. So when we look to medicine, we heard nicely from Bruce this morning. So we have fibrosis in myelofibrosis, we have fibrosis in liver, we have fibrosis in renal, we have fibrosis in lung, and the fibrosis in GvHD is mainly in skin. We have also scleroderma. So is this all the same fibrotic we are talking about? And what can we learn from others? So when we look for, let's say, for instance, scleroderma, there's some data about autologous transplantation, and they have a complete resolution, or they used high-dose cyclophosphamide as well. So what is your opinion regarding learning from others, and is it all the same? Because we have, not all have inflammation. So in myelofibrosis, we have inflammation, but not all the others have inflammation.
So it's a good question. I'm going to start by disagreeing with you for a moment, saying that we predominantly have fibrosis in the skin. If you do biopsies of the lacrimal glands or the minor salivary glands, you see extensive fibrosis as the mechanism behind chronic ocular dryness and chronic xerostomia. So I think there is fibrosis in all of the affected organs. I don't know if the mechanism of action in the lacrimal gland and the small bronchiole and the skin and the liver is the same. So I don't know that for a fact, but I think if you look hard enough, you'll see sclerosis in all affected organs in chronic GvHD.
Maybe to echo and to add, yes, we can learn from other diseases and actually, for instance, tocilizumab, which is used in the rheumatoid field and approved where had been shown to be in a subset of patients effective. There is no interest of the company to go for approval in chronic graft-versus-Host disease, and there are obviously other agents, but it's always good to kind of ask the rheumatologist, this is my approach, if I'm ending kind of the fourth line, what would you use in case you would be faced with such an autoimmune disease? And that's a very good learning thing.
Yeah, invariably the rheumatologists say azathioprine. And I don't know what to do with that answer.
Yeah. So, I mean, thank you for the session. It was great. And thank you, Zina, for the summary of new results and new drugs. That was also very useful. But going back to the shifting of the paradigm, I had a question for each of you, because I think that sometimes it's difficult to reconcile a lot of the things we said. This morning, we heard, and we are all very keen on doing combinations, and we've heard some combinations from Zina. And then, if I understood correctly, Daniel, you've told us that by no means we can just treat a patient with something and then add something on. And to me, it's not very different, because the reason you add something on is that you may have some response in some organs, but you're still missing some other organs. And the whole philosophy of combining is precisely that with different mechanisms, you cover different things. So how is that different in terms of paradigm of treatment?
There's an easy answer on that. We just don't know. We haven't explored systematically. The only warning I wanted to share is adding a kind of combining more than 3 agents becomes a risk, a situation where you have at least one agent on board which doesn't work, but causes toxicity. And also consider financial toxicity in that context.
Mm-hmm. Yeah, and also, of course, that we don't learn. If you just keep adding things without really monitoring, exactly. You don't learn what's happening. And then in that same line, to Corey, we were also looking at all the biology, all the advances in the biology, and how different mechanisms of action and different targets help us, direct to particular features and what particular responses and treatment on patients. And then you tell us that, Rockstar, that it doesn't matter whether it's a ROCK inhibitor or a JAK inhibitor, that there's going to be crosstalk. The molecules are pretty much the same. They've got this little other thing added there that no one knows what does. And then pretty much does that negate really the whole pathway of the pathophysiology and the mechanisms and the targets, and we just have to try these drugs and see how they work?
Yeah, I mean, I didn't purposely mean to be a nihilist. I think we have to start by forward thinking. So what is the pathophysiology that we currently understand, and what is a drug that might work in that given situation? But then at least be open to the possibility that we probably don't know everything that we think we know, and to continue to look beyond what we think we know.
Thank you.
And to add, the side effect profile is obviously different. So the small addition of molecules obviously changes at least that.
So no, nobody from the audience. So I would maybe ask you, Corey, or both of you, can you share with us a bit of the state of the art? So you have a patient in front of you, and he has some kind of manifestation, and then you say, I would rather use this or this. Is there something that you could share that you have from your experience that would be practical?
I still have a fairly algorithmic approach to the management that takes into consideration FDA labeling to get around arguments with insurance companies. And so one has to always consider toxicities first and foremost. So what does the patient in front of me, what would they predict it to do poorly with, rather than what would they be predicted to do well with, right? So understanding that a patient who has pre-existing big elevations in liver function tests, this is not a patient who I'm going to try belumosudil. The patient who has a platelet count of 40,000, this is not somebody I'm going to start with ruxolitinib. So it's sort of first do no harm and then hope you do some good. That's sort of how I approach it.
Yeah, just and I do exactly the same. Just want to add some thoughts to illustrate how this works. So the label in second line is ruxolitinib, but there are clear contraindication for ruxolitinib. This would be something was usually a patient where you could consider ECP among other options. For third line, belumosudil, except the situation just described, would be an option. In EU, it would be only third line agent approved. But it's always good to have this kind of internal checklist, comorbidity, biology to some extent. If a patient never had any B cell in the whole career, rituximab is likely not be the optimal agent. If you have a rapidly expanding B cell system, that may be an option, not saying that you must use rituximab in such a patient. It's just kind of a little point on the list. That the next question, what worked and what didn't work in the past? Then one agent excludes the other. So like I mentioned, Ruxo MMF combi is probably not the wisest one. What is available at my institution? ECP is a nice treatment. If the patient living 500 kilometers away and has no venous access, it's obviously not an option for this patient. And kind of having this internal checklist and a checklist of agents you ever used, then you end up with 2 or 3 max option. And this can be used then resolved by the shuffle mode. And then I tell my residents, if you apply this list and you end up with 3, just go for whatever you like. And we just look at me, yeah, we don't know. And we really need to work on that.
Nadira has a question.
So to add up to the, let's get more practical. If you had a patient that developed very late, like past 2 years post-transplant, late, very fast progressing sclerotic skin GvHD, not responding to steroids, you added on ECP, but ECP takes time, not really getting better, getting worse by the day, so you switch to ruxolitinib, still can't taper off the steroids because apparently he's not really responding to ruxo, he still needs a lot of steroids. And then you switch to belumosudil, or do you keep ruxo and add on belumosudil? When do you start with combination in a setting where you don't have access to the combined drug?
So lots of questions in that one question. I'll say that I never start combination simultaneously for the reasons that Daniel described. If you have a side effect, you don't know which one is causing that, and if you have a benefit, you don't know which one is responsible for that. My general approach to patients who are failing or need additional agents is asking the question whether they had a response at all to the prior agent. And we know that about 3/4 of patients are going to respond to whatever drug you give them. And so in the situation where the patient had a partial but incomplete response, I'm an adder. But in the situation you describe where the patient had nothing meaningful or nothing that you could tell or nothing that the patient could suggest as being of benefit after 8 to 12 weeks, then I substitute. Because I don't think we have evidence yet that there's synergy between the drugs. I think they're probably additive. So in a situation where you have nothing to go on, I swap. In a situation where you have any amount of reasonable response, I add.
Doing exactly the same thing. Just to add, so if a patient has kind of a mixed response on Ruxo, which is not very infrequent, I usually switch to belumosudil with a short overlap of Ruxo, not just to go off. And then taper off the Ruxo. If the patient is getting better on the combo and losing the response on once I taper off the Ruxo, those would be the patient who would stay on the combination. But at least you have some indicator that you need both.
Oh, thank you. That's very useful.